Hello, everyone. My name is Dr. Richard Horowitz, and I'm the co-host of the Dr. Talk Healing Lyme Summit 2.0. It's my great pleasure today to introduce to you Dr. Nicola Ducharme. She's been doing Lyme disease for over 20 years. She's in California, and we are going to discuss today the factors that are interfering with Lyme treatments, with people getting better. Nicola, thank you for joining us today. It's a pleasure to see you.
You're so welcome. Great to be here.
Yeah. So why don't you tell people a little bit about yourself, how you got into Lyme, kind of how you got into doing what you're doing.
Yeah, absolutely. So, well, I grew up in Australia, which was sort of an influence in all of it because I had this super healthy mom that, had us eating well and out bushwalking and hiking and doing all the healthy things. And so I got interested while I was in Australia in sort of in the fitness industry, and then through that into nutrition, and through that into naturopathy. And so I did become a traditional naturopath in Australia, which is the only qualification there is in Australia. There is no naturopathic medicine there. So I was on that path already, but then went traveling in my early 20s, like us, young Aussies tend to, and backpacked around and spent 3 months backpacking around the States and ended up in New York. I just fell in love with New York. Like I couldn't get enough of it. I'd just go back to Sydney and find another way to get back to New York. And so I ended up finding an internship program that places young Aussies and young Brits in New York City with a job, a visa, health insurance, and an apartment, all of the things. And as quote unquote luck would have it, I ended up in a posting at Columbia University College of Physicians and Surgeons. And so I was in the research institute there, neurology and public health. And really that was a lot of what inspired me to look at my own life and think, gosh, I could do more. I could, I could really go somewhere with this if I set my heart and soul to it. And so a family friend said, oh, you should go to Seattle, to Bastyr, and do naturopathic medicine. And I did a quick, Google or whatever it was back then. And I was like, oh, Seattle. Oh, it's 4 years. Oh, it's a doctorate. Oh, it's 35 credits a semester. No, absolutely not. Like didn't even take that on. And then I processed it and I was like, okay, so there I was 5 months later in Seattle, embarking on my doctorate in naturopathic medicine. Got through that 4 years and then moved to San Diego in 2003. And when I first went into practice, I was very, very blessed to be connected with a brilliant doctor named Dr. Kurt Wooler, and he treats kids on the autism spectrum. And so he taught me all of that work. So I really did a lot of that work with autism for the first couple of years. And then what happened is that I started seeing some of the moms of these kids, and they'd come in to see me and they'd say, oh my gosh, I'm exhausted the whole time. Everything hurts. I'm getting these headaches. But they just sort of put it off, right? Because they're new moms, for one, like the new mom thing. And then it was like, oh, you're a mom of a special needs child. There's more stress. Mm-hmm. And then after a while, they're like, this is ridiculous. Like, I can't go on like this. So I would do a functional medicine workup, adrenals, heavy metals, Lyme disease, all food sensitivities, all the things. And it was uncanny how frequently Lyme came up as positive.
And this, by the way, this is going back even 20 years ago.
This is 20 years ago.
When you were starting to see how often Lyme was coming up in the diagnostics.
Yeah, in my patient base in Southern California. Now, it's not to say that everybody contracted it in Southern California. We do have Lyme here, there is no question. We have less than other parts of the country. But some people, like Central California is a hotbed, Northern California, the Midwest, all over the place. And so I started working with these patients and learning about Lyme. And at the time, I felt like, there were lots of autism docs around, but there were very few Lyme docs. I mean, to this day, there's very few Lyme docs here in San Diego area.
Right.
And so I really kind of delved into it. And at first, I was like, I was not going to prescribe the antibiotics, right? I was like, oh, Dr. Harris, here's a patient. No, Dr. Yang, here's a patient. Like my mentors who I trained under, Stephen Harris was one of my major mentors, and I did my physician training program, ILAD's physician training program with him back in the day. And so I would sort of co-manage with the naturopathic aspect. But then over time, as I learned the protocols and got more comfortable, I realized that there was a need for someone who could manage both the antibiotic parts and the naturopathic support. And so that's kind of really where my approach to treating Lyme was born, is that really like integrative approach of, antibiotics can give people their life back. They're not for everyone, and they have their downsides and all of the things, but they can be life-saving and life-changing. But I would never give someone antibiotics without supporting their body and supporting the liver function and their gut and all the things to try and offset. So that's kind of how it started. And then from there, I mean, it's pretty much all I see now. Can't remember the last time someone came in and said they just had the flu or a cold or something. That doesn't happen. But I love it, and it definitely feels like a calling for me. And I feel also very fortunate to have been able to work with some of the patients in Australia where there is still no help for them. There's still no recognition
Well,
of
I mean,
Lyme.
Australia, when I've spoken to the Australian government, I mean, and I've gone to their Senate committees and the rest, and I've
Yep,
spoken, they're still claiming there is no Lyme in Australia, although they have hundreds of cases of erythema, migraines, rashes, and these
correct,
mysterious illnesses. And
correct,
as you know, I mean, the controversy in Australia is actually one of the worst in the world because these
correct.
people have to leave Australia to go get treatment.
Absolutely. And so that's what everyone was doing. And then that became very problematic during quarantine and COVID. People couldn't leave Australia to get treatment. So it's a real disaster there. It's very, very heartbreaking. Um, so, I do get to work with some of the patients in Australia and try and bridge the gap. And, I'd say 10 years ago, there were a handful of Lyme literate doctors there doing good work that I could collaborate with, and they've just been restricted and restricted as the years have gone by. So it's a very, very sad situation in Australia for
Yeah.
sure. Um, so that's, again, it's one of the things I love is to be able to do what I can from afar. I can't prescribe in Australia. I'm not licensed in Australia, but I can at least facilitate testing and kind of give them some guidance and herbal protocols and things like that.
Yeah. So great. So, as all of us, I mean, we kind of fall into this by accident. As a board certified internist, when I moved to the Hudson Valley, which was one of the Lyme hotspots in the world at the time, it was the biggest actually in the US. You walk into these things, you get sick patients, and you go, all right, they got better with this, but why are so many people still sick? And you go on a journey, right, to figure out why they're sick. And
Yeah.
I think we all come about after a while to the functional medicine approach and the antibiotics that this is kind of at this point some of the best approaches. So let's talk a little bit about what you think is missing in Lyme treatment today, because I've spoken, to a couple of the other experts. From your perspective, what do you think are the most important things that patients need to know about Lyme treatment?
Yeah, so there's a few different things on a few different levels. I mean, the first I'd say is that, the role of diet and lifestyle nutrition factors is so key. If people aren't willing to get the sugar out of their diet, if they're not willing to kick some of the really inflammatory foods like gluten and dairy to a slightly lesser extent, but it's up there. And just, paying attention to sleep habits, stress management, working on trying to get into the parasympathetic mode and getting out of that fight or flight kind of mode. I think that foundation of like the things that people can do for themselves at home is really important.
Mm-hmm.
Um, I think that there is a huge role of like trauma and limbic system dysfunction in a lot of patients. So, and to be clear, this is not me saying this is all in your head, it's all psychosomatic kind of thing. However, I have seen my patients where they have gone back and done the work to kind of work through childhood traumas or previous traumas. Like, it's always that expression, the body keeps the score, right? Like your cells can hold
It's a great
trauma
book,
and
by the way. Yes.
memories. So I think that's a factor. One of the things that I see too in patients, and about 12, 13 years ago, I actually was toying with the idea of going back to New York because I talk about my love affair with New York, but I had a practice here in San Diego. So I spent a year going back and forth. I took practice in Connecticut and I spent 2 weeks in San Diego, 2 weeks in Connecticut for the whole year. Probably one of the most fun years of my life. It was a great adventure. But I went with the sort of the perception that there would be lots of Lyme literate doctors in Connecticut who could do the prescribing, and I could sort of handle more of the naturopathic part, and we could sort of have these nice collaborations. And what really surprised me is how many docs, and there may be other reasons for this that are more like, watching out for protecting licenses and whatever. So I'm not going to go into all of that. That's beyond the scope. But how many docs were still like giving a single antibiotic, for example? So, one of the things, I mean, I think the pleomorphism element of Borrelia is key, and the recognition of co-infections is key. So just to touch on both of those, we know that the Borrelia bacteria can exist in 3 different forms. We've got the spirochete, the cell wall deficient, the cyst form. I tell my patients, think it's like you've got a caterpillar, a cocoon, and a butterfly, like theoretically the same creature, but they look and act very different depending on where they are in their life cycle. But the difference here is that it's not just a single linear, unidirectional kind of movement. So, and I was always trained and taught, and this is how I prescribe, that to be thorough, we have to be addressing the multiple forms of the Borrelia bacteria, that, you know, a single antibiotic is really going to be enough. And if anything, maybe more harmful in the end, because it just sort of pushes the bugs into that cyst hiding mode where, you know, the patient feels better for a while. They've been on, you know, doxycycline or amoxicillin or whatever. They do better, they come off the antibiotic and then get worse right away. And I think that's what I call the bugs are coming back out to play, right? They've gone quiet, but now they have a chance to come back around and take a hold again. So, I mean, I think that is a really important piece of making sure that antibiotic protocols are comprehensive to cover the different forms of Borrelia. And then the other part of that I see in terms of the prescribing, and this isn't purely antibiotics, this can be applicable to herbals as well, is not recognizing co-infections. And I have a system, I mean, I love IGeneX testing. I think it's the best testing we have available for Lyme and co-infections. I've used them for 20 years. And I do my own little co-infection provocation, which is a strategy that I developed years ago, and it's been so incredibly helpful. So how it looks is, you know, make sure a patient's detoxification is well supported, because that's the foundational thing I do before starting any antimicrobials. And then it's 3 steps from there. Step 1 is I introduce a single herb that targets Borrelia. And then say a week or 10 days later, we add something that targets Babesia. A week or 10 days later, add a herb that targets Bartonella, because they're the 3 biggies in my mind, the 3 Bs, Borrelia, Babesia, Bartonella. And we gauge how people respond at each step. And that has been incredibly helpful in helping me to determine which co-infections are present, which co-infections are kind of causing the most problems, and to some extent, which co-infections may be, you know, attributing to which symptoms. So
Yes.
sometimes
And I agree with you 100%, because, and I'm surprised that I think at this point, a lot of doctors are aware, but, you know, it's in our community. You know, the problem is you're absolutely right. I mean, every person pretty much who's walking in these days has the 3 Bs of Borrelia, Babesia, Bartonella. I don't even think there's a doubt about it. And even when I don't find Bartonella on the initial screen, usually if I look hard enough, it'll end up showing up. Like if we take multiple antibiotics, go into the intracellular compartment, we kind of flush these bugs out. I've seen it happen with tularemia, with BART, with others. And you're right about the pleomorphism. In fact, you started doing this years ago with multiple antibiotics, as did I, but it's recently, in the last couple of years, when we did the Dapsone trial in culture, we showed that 4 drugs was better than 3, and 3 bugs was better than 2, and 2 is 1. And Hopkins showed the same thing, and it's now coming out. But you're right about the pleomorphism. The thing we were missing years ago, and Hopkins came out with it, was the biofilm persistiforms that, apart from in the pleomorphism, the cell wall forms, the cystic, cell wall deficient, intracellular, these biofilm persistiforms for me have really been the kind of the wake-up call, and that's where rifampin, dapsone, pyrazinamide, methylene blue has worked. But yes, I'm in 100% agreement with you. Now, when you're doing this and you're using these herbs to kind of get a sense, because with Babesia, you know, for the most part, 99%, it's malaria-like. It's day sweats, night sweats, chills, flushing, air hunger that you can't explain with cough, Bartonella, pain in the bottom of the feet, the stretch marks, bad neuropsychiatric, immune deficiency, bad POTS, right? There's certain markers. What herbs are you using specifically in your protocols that you're finding to stimulate it, that, you know, tell you what direction it's in?
Yeah, so like I said, I use single herbs. So Borrelia, I use teasel root. Babesia, I use artemisinin, and Bartonella, I use Hatunia. And, you know, recognizing that it's not a perfect science, right? Because in nature, plants don't just target one thing, right? And like antibiotics have been developed to be more specific. Plants have not been developed by nature to be as specific. So, you know, we've got to recognize that there's some overlap, but they're the 3 that I have found consistently have an affinity for that particular pathogen. So, and to
Oh,
your
sorry. So
point,
repeat it again. So Hutinia for the BART, which
yep,
we use in some of the Chinese, Artemisia babesia, and what was the first one?
teasel root.
Oh, teaser root. Yes, of
Yep.
course.
Yep. And so I love those 3. And I mean, there are other combination formulas that I may integrate later on down the road with cat's claw and Japanese knotweed and Hatunia and all of that, or andrographis, I mean. But I like singling out the 3 just as a starting point, just to keep it simple. And then I'm looking, and to your point, you're absolutely right. Like there are some hallmark symptoms of Babesia. There are some hallmark symptoms of Bartonella, but there's also so much overlap that it's kind of helpful being able to get a sense. Like I have some people who say, oh yeah, the teasel root, that was fine. Didn't really notice anything. The artemisinin on my night sweats kicked up or whatever. Okay, no great surprise. Oh my gosh. But when I started the Hatunia, like my pain worsened, like my body pain. And so body pain is something that we may think is more a Borrelia thing because Bart is more like, from here down, I'm fine. From here up, I'm a hot mess. But then if their joint pain really flares up, then it at least clues me into like, oh, that might be Bart for them. It's less common that it would be so, but for that person, it gives me a bit of a sense of like which co-infection is driving which symptoms. And that process helps me then to put the next steps together. And if the next steps are antibiotic protocols, just helps guide me where we need to go first.
Right. So apart from lack of recognition of co-infections and the pleomorphism, you were talking earlier about detoxification, that maybe enough doctors are not doing enough detox work, working the functional medicine pathways. Lifestyle, of course, is important. And when you were talking about diet, when we check people for leaky gut and we do zonulin and 95 IgG food, I mean, the majority of everybody I'm checking at this point, right? They've got inflammation in their gut. Their zonulin levels are elevated when I can get it. They've got mast cell activation from eating the wrong foods, apart from the Lyme and the bark causing it, or the mold. And
Yeah.
you're also finding, like I am, that mold toxins. Could you say mold toxins are showing up in 9 out of 10 patients the way they are for me at this point?
Totally, totally. So that was another big thing that I was going to say that really complicates things. And I think, I've had to learn this. I mean, I know that in your decades of practice, like you evolve over time and you learn things. And for me, it's been an acceptance too of, oh yeah, like this mold is it's really a big deal. Like, yeah, I really need to pay attention to this. Like 5 years ago, I was like, I don't really want to go there. Like that.
And by the way, I'm the same way. I used to joke with Neil Nathan and I used to joke about 5 years ago. I
Yeah.
used to say, Neil, you see primarily the mold. I'm seeing the Lyme. I do find the mold, but the three B's are the top for me, followed by the
Yep.
mold. And
Yep.
now it's kind of like
Yep.
running head and head because if I don't address the mold, so now it's like I'm doing a 9-week Dapsone protocol, but the minute I stop, it's like go detox the mold.
Right.
So I have no choice but to pull out the mold toxins, or
I 100% agree. So
yes.
yeah, I sort of had to like sort of eat my words a little bit. I actually brought in a practitioner who was like, okay, you get shoemaker certified. So I'll send these people to you for that. And then, but now there we are doing mold as well. So I think that is a huge part. And one thing, and I'm still learning this, like, because a lot of practitioners out there, they're like, you have to go after mold first, because if you don't get rid of mold, they won't recover from Lyme. And there's some truth in that. And like, I had a girl yesterday completely prove me wrong. Like, so we just diagnosed her with Anaplasma, Bartonella, and high mycotoxins. They were the 3 standouts on her labs. And her pediatrician had agreed to put her on Doxy. And so they were very keen on starting the Doxy. It wouldn't have been really where I would have started, but I sort of came in a little bit later in the game. And so I said, okay, well, let's do that as a trial. We'll do that, and that will give us some clue about what the role of the pathogens in this. Well, I talked to them a week later, and she's 50% better. So, and so there are cases where, and then I talked to her parents, and I said, okay, so that's a good thing. We'll keep that going for her, and we'll start chipping away at the mold. And obviously, the first step there is environment and, making sure there's no current exposure. And then, with the Lyme and mold piece, I also look at like, what are the things that we have in common? Like, what are the things that are going to help both, which opening up those detoxification pathways, supporting with the glutathione, supporting glucuronidation is a big one I have found, making sure the bowels are moving and toxins are coming out, sweating if possible, binders, like all of those things that we use in mold treatment don't hurt in Lyme treatment either.
Mm-hmm.
So I try and look for the overlap of like, how can we get, the most value out of the most succinct kind of protocol so that,
Yes.
that there's not 2 totally different things running at the same time.
Absolutely. And you're finding, just as I am, the mast cell activation is playing a big role also. You're finding that overlapping
Yeah.
because,
So,
yeah, please speak a little bit about that.
yeah, so the mast cell is becoming to be a huge deal too. And I see mast cell more, in my opinion, I may not be right, but I see that more triggered by mold than I do by the pathogens.
Mm-hmm.
And so and so it becomes the order of go, right? It's like we've got to look at like how far up we've got to get the mast cell calm down sort of as a top priority, because if there's so many histamine reactions, a lot of patients aren't then going to tolerate the treatments that they need to be able to take to get rid of like the mold and the infections and things like that. So if somebody is struggling with mast cell stuff, that has to be addressed sooner rather than later. Otherwise, they just won't be able to go further. These are really sensitive folks that can't take anything.
And and it's become complex because the tick-bornes do stimulate mast cell, but the mold also does it, and so does leaky gut, and so does long COVID. So I
Right.
mean, now, so when we looked at the long COVID, the last article we published this year in Microorganisms in 2024, we did an MSIDS review of all 16 factors. All 16 showed up in long COVID, just like they do in Lyme.
Yeah.
I did
Yeah.
a search on Alzheimer's, all 16. I mean, it seems like most of the chronic diseases we're dealing with these days, there are these overlap. I call them like the 6 rivers of inflammation and the 10 downstream effects. And the 6 rivers of inflammation is the infections, bacterial, viral, parasitic, candida.
Mhm.
And also, you're also seeing an overlap a little bit of candida sometimes in the gut in these people, mimicking the same symptoms, right? Where if they don't get off carbs and
Yep.
really get the sugar down, the inflammatory response just doesn't treat.
Right.
But it's the mold and the toxins and the heavy metals and the wrong type of microbiome in the gut and the leaky gut with the mast cell and not sleeping, stimulating IL-6 and vitamin mineral deficiencies. Those things all contribute to inflammation. And you're absolutely correct, by the way, about the trauma. Just yesterday, this was a fascinating case. This guy's been following me for years. He's done the Dapsone protocol. He had the usual, culprits. We've treated him for mold, but every once in a while would get these reactions. He used to say to me, I feel toxic. Like I get in a sauna, I need to sweat it out and I feel better. I would
Mhm.
get some back pain, some stuff, and he could never identify where the trigger was coming from. He started doing primal trust, one
Mhm.
of these neurofeedback techniques and limbic retraining, along with Annie Hopper, DNRS, and the GUP to AR. And he
Yep.
said, and I've told this to my wife also, who I'm trying to convince to do this because my mother-in-law is still causing her vagal dysfunction a little bit. I said, sweetheart, really? So he let me know within 6 weeks of starting the primal trust that these inflammatory reactions he was getting that he thought was just tick-borne. It turns out he recognized he was holding on to emotional trauma. And it's exactly what you said. It's not telling people it's in their head, but you can't like separate out the mind-body connection at this point in people. And everybody I know, including myself, including my wife, everyone, we've all had trauma. And I'm even thinking of starting next year when I have some more time, starting a vagal and limbic retraining. I just bought myself an Apollo Neuro, just like I
Mhm.
got one from my wife, my friend, because it's like everybody I think needs this as part of their healing program at this point.
Yep. Yep. Yeah. And I like the Apollo Neuro. I do find some of my more sensitive folks don't tolerate the vibration effect of it though.
Hmm.
But I think the limbic vagal piece is huge. And there's just, it's a lot. And so that's where, and they're exactly the 3 programs that I talk to people about too, the DNRS, the Gupta, and the Primal Trust. And I sort of have patients go off and kind of look each one up and research it a bit and see what resonates.
Hmm.
Um, but I've had people come back to me and go, I just don't really want to do an hour a day. And everyone's in a different place, and everyone gets to make their own decisions and has agency over their own body and their own choices. And that's one of those things where I'd say, but what's it worth to you? That's something that you can do at home. It's something that, if you're at home, you're unwell, it's not, you have the time. It's just applying the discipline and enforcing the habit of it. And as Dr. Nathan would say, even if you just do 15 minutes a day, it's better than nothing. Like, don't do nothing because you can't do everything if that feels too much and too
I,
overwhelming.
I, I agree. It's better. Like I figured out with my exercise program, if I don't have a full 20 minutes of cardio, like on my treadmill at 12%,
Mhm.
even if I have 10 minutes quickly to get that cardio up, do some hits, some high intensity interval,
Mhm.
I have it so it's 7 days a week. Like literally, if it's the evening and I haven't gotten my exercise in, I've
Yeah,
trained my body get in the car. I think it's the same thing with these programs, but
yeah,
you're right. You need a structured we all have busy lives,
yeah,
but I think the limbic, I was talking to my wife this morning, like starting the new year, where am I going to find time if it's 15 or 30 minutes, not an hour? I wouldn't find
yeah,
an hour. But
yeah.
how am I going to do it? Because my food sensitivities are still there. I could
Right.
think of dairy, and I'll start to itch. I
Oh,
mean,
really? Ah,
and I've done, I've healed my leaky gut and it's much better. But
Yeah.
I know that I need to rewire a little bit just from, having this stuff for years.
Look, we all need to rewire. I mean, we're in modern Western society and life is stressful and there's things. I mean, I'm very, very, very fortunate by the grace of God, enjoy very good health and fitness. And a lot of people assume or at least ask me if I have Lyme because a lot of practitioners get into this area because of their own journey or journey with their family. And I get to say no, by the grace of God, I don't. Um, However, we all have our stuff. We all carry around our stuff, and we have our sort of weaker points in our health. And some of it comes down to genetics, some of it comes down to lifestyle choices, some of it's just, how our nervous systems are regulated. But I
Mhm.
think that piece is so huge for a lot of people.
Yeah. So by the way, what newer therapies are you using and liking these days? I mean, we've talked about, and I'll speak to you a little bit about your experience with Dapsone and the mold and rest, but are there newer
Yeah.
therapies you're liking these days, like that you're finding are effective in your patients?
Yeah, so I mean, we have started doing so. I mean, ozone is not new, I will say, and it's not new to us either. But I bring it up just because I love it. I do
Mhm.
love MAH ozone. We did 10 pass ozone for a while. Ended up being a little bit more problematic than it was worth for us, just because it set off such big Herx reactions and it had a higher demand for heparin, which just was a little bit more of a risk factor. So we've kind of settled on just doing the single pass MAH ozone and love that. We have also started doing SOT therapy, which is, I know, a little bit more controversial. It's a little bit hard to describe. It's somewhere between a gene therapy and an immune therapy, but essentially, we take blood, send it off to a lab in Europe that makes a remedy. We have to have a positive test result for the pathogen that we're asking for the remedy for within 6 months. And it has to be down to the strain, not just Borrelia, but Borrelia burgdorferi.
Right.
So we send it off to a lab. They create a remedy that is specific to that strain in that person's blood. So if you then infuse that formula in somebody else, it would do nothing. So it comes back to us just as a little crystal in a little vial, and we reconstitute it and then just drip it by IV into the patient. And what that can help with is stopping the replication of the pathogen. And so it works in the body for up to 6 months. And I also do antimicrobial therapy during that time we want to kill off the active pathogens and do what we can. So it's not a standalone therapy, but as an adjunct, we have had good results with it.
No,
And
I've had it a little bit all over the place. I mean, I don't recommend it often. I've had patients come to me who've done SOT.
Mhm.
And I mean, certainly some people have gotten help, but I've also seen people get no help, whatsoever from it. They've tried it for like Epstein-Barr when it's active and some other ones. Do you have a sense why in some people it might be helpful in others? And I mean, do you think it's curative? Because of course, my question is they haven't really published the results. These are
Mhm.
biofilm persistrobacteria with, Borrelia and Bartonella. I don't know any evidence. I mean, it may be that it actually is affecting these forms. Maybe the immune system can get to it, but do you have a sense why it's effective in some, not in others? And what do you see with the long-term results from it?
Yeah, so I think it depends also on like trying to, as much as possible. Well, the first thing I'd say, there's no one thing that works for everybody, right? So that's the thing. And it is a sort of higher cost therapy. So it's a little bit more of a risk in that front.
Yes.
Haven't seen a lot of negatives from it, other than some people do get Herxheimer reactions in the beginning. Um, I think it's picking the right target. So yes, we want to look at lab work and see what's popping up there, but we also need to match that with the symptom presentation of the patient and make sure it makes sense what we're asking for. There is definitely a recommendation to do tick-borne pathogens before Epstein-Barr or before viruses.
Mhm.
So if people go in and do Epstein-Barr first, that's probably the wrong order if they have the 3Bs. And also Epstein-Barr, they do say it may need 2 or 3 SOTs to really be effective. But I do less of the Epstein-Barr, more of the tick-borne pathogens.
Mhm.
I think with any of these things, just like I said, you still have to be killing off, you still have to be breaking down biofilm, trying to get to those persister cells. Like, doesn't replace the need for that.
Yes.
So maybe that's where some people are kind of not doing enough in the treatment throughout that 6-month period and just sort of expecting SOT to do it all, which it won't. And
Right. I thought, in fact, they said there's a period of time they didn't want people using the antibiotics after the SOT. At least, again, I don't do it, but that's what I
sure.
heard. Is that true, or it's
So it's 2 weeks. so no antimicrobials 2 weeks before the blood draw that actually goes off to the lab in Europe, Greece, I think. 2 weeks before the infusion of the SOT, and then like a week after, and then you can go back on.
Okay.
Yeah.
Good. And
Yeah.
and what you're starting to use some of the newer therapies like dapsone, methylene blue, tafenoquine for babesia. Why don't you speak to
Yep.
people a little bit about your experience with these?
Yeah, so I mean, I'm very encouraged by it. I have put a few people through your double dose dapsone protocol, and I have more people interested in that. So I'm definitely going to be getting more into that. I'm also kind of looking more into just prescribing dapsone at the lower doses for at least as a starting point for people who may feel like they're too sensitive to go into the double dose dapsone right off the bat. So that it's not all or nothing, right? So that we can utilize dapsone in sort of more moderated ways, at least for a period of time. The tafenoquine I like. I think that's a good, it's sort of, it again doesn't replace the Mepron, Malarone, those kinds of things, but it does give that boost. Now, back in the day, we used to do Lariam for the same reasons, right? A little bit more of the blood-brain barrier penetration, a little bit more, helpful for the neuro aspects of babesia. And then that sort of got a bad reputation, so it sort of went bye-bye. But so I like that there's sort of a resurgence of this kind of family of medications without specifically being Lariam. And I have found tafenoquine, at least, has been beneficial without a whole slew of negative side effects. Methylene blue, I like a lot. So I have been incorporating methylene blue with a lot of my patients, not only for the sort of the Borrelia bartonella persisters and whatnot, but just for the mitochondrial support, for the cognitive support. Like a lot of people get more energy from it, more clarity. I personally have found that I've had to start lower dosing in a lot of folks. So I would say an average kind of starting point for me would be probably 10 milligrams and do that once a day for a week and then go up to twice a day and then go from there with sort of an average of 25 milligrams. I rarely go above 50 milligrams twice a day because then I feel like I start seeing side effects of people getting like overstimulated and feeling like wired.
The way I've gotten around it is a very slow increase during the dapsone protocol because, as you know, when you increase the dapsone dose, the methemoglobin gets worse.
Yes.
I found that if I just increased it slightly week by week, by
Mm-hmm.
50 milligrams, 100 mil, I found the
Mm-hmm.
tolerance generally has been fine.
Yeah.
Of course, I get people off all their SSRIs and psych drugs before I do it.
Right.
By the way, the other interesting thing about methylene blue, the article just came out recently, it's killing COVID. So it just came out this past week that it may even be micromolar concentrations of methylene blue. This may be the next drug. I'm not sure it will be instead of Paxlovid, but it's possible
Right.
with it because instead of the Paxlovid rebounds that people were getting,
Yes.
they may want to keep them on low dose, and might even be something like 10 milligrams twice a day for 2 to 4 weeks. But it's
Right.
interesting. It just got published for it. But regarding the use of low dose dapsone, I should tell you because I'm not sure you're aware. I've had elderly patients who said to me, I couldn't do the higher dose protocols. I just put them on 50 milligrams of minocycline with 25 of dapsone, which you barely even get anemic. And
Uh-huh.
they would come in a month later and go, my cognition is great. I feel so much better because it's lowering down neuroinflammation.
Yeah.
And it's not like I've got gazillions of patients doing it. But what I found in the patients that have done even the very low dose dapsone for long periods, I'm talking a year and a half, and then stopped it, they didn't relapse actually as much as I would have expected. I would have thought like, oh, I needed the higher dose protocols to kill the Lyme and the BART. It
Yeah.
seems like it still knocked down the load of the persisters enough. And
Yeah.
when
That's
they came
awesome.
off, although they did notice a slight backslide,
Yep.
it was not what I would have expected. So I think there is some long-term benefits. And I've certainly seen, like my wife, who is now in remission for 6 years after doing double dose dapsone. She
Yeah.
wasn't active for BART when she finally took it. She did 50 milligrams for a year, felt great, stopped it, relapsed, PCR positive in her blood, went back on 100 for 6 months, felt great, stopped it, relapsed. Now she had done a year and a half of lower dose dapsone below 200. She
Yeah.
only did 1 month of 100 twice a day, and she's been in remission for 6 years. So it is kind of like the total amount of time you're on the dapsone, even if it's lower dose. I think it's making a difference. I'm just trying to use these 9-week protocols so I don't have to leave people on antibiotics. You know, we started off the conversation as a naturopath and functional medicine. You don't want to give long-term antibiotics to people for the microbiome if you can avoid it.
Right.
So I'm trying to get it through, but there is an advantage in some people.
Yeah.
And I think kids, we need to do more studies on this. I think for kids 50, 75, up to 100, it may even be fine without having to do higher doses. Bart may be a little bit of a different situation. We
Yeah.
need more studies, but I think, yeah, there's going to be some room to kind of experiment with these different doses over time.
That's awesome. That's great. That's great information. And yeah, and sort of that's kind of where I want to head is getting into more depth zone dosing, like even the lower and more moderate dosing, with more consistency for people who are sort of scared of doing the big double dose depth zone protocol.
Yeah, you know, the people that are the easiest to do for those listening, if you're a woman with a hemoglobin over 14 and a man with, 15, 16 hemoglobin, literally, I can close my eyes like a dartboard, throw it and get them through the 9-week protocol. Only because ever since we discovered the higher doses of methylene blue up to 300 BID with other things that lower methemoglobin, cimetidine 400 BID lowers methemoglobin. I only have to use 1 Plaquenil a day when I do it. Glutathione, vitamin C, vitamin E, ENADA, NADH, they all lower methemoglobin. So the average methemoglobin on quadapsone for the 6 days for Bart, it averages about 5%. And most people will get a little symptomatic, but not dangerous at all. And that's kind of how we got them through it, is just by adding all these antioxidants to it. But clearly the easiest people to get through it, the ones with the highest hemoglobins, yes, they will herx, they'll feel worse, but it kind of speeds up the protocol to get them there. And then it's usually pulses. With Bart, we're finding like a 2-week pulse of antibiotics every 2 months, usually as long as the mold is gone and the long COVID is treated.
Yeah.
And we're evaluating pravastatin or atorvastatin with Maraviroc now. I spoke to Bruce Patterson. He's going to be part of this Healing Lyme Summit. The study that just came out a couple of weeks ago, I mean, it looks useful. I need to see enough personal experience. Have you tried the Maraviroc pravastatin yet to see kind of in long?
No, not
It
yet.
is worth a try. It's very well tolerated. It is very well tolerated. It's shutting off some of the monocyte activation in these people. They come back with these radiance diagnostic profiles with the 14 cytokines, where the VGF is high, with SDCL40, these vascular inflammation markers. And I said to Bruce, how do you know it's the spike protein that's causing the vascular inflammation versus Bart with the VGF? And he says, I don't know. And I said, you're probably going to find it's both, right, in a lot of these people, because now they're finding the spike proteins in brain, bone marrow, and meninges. It's becoming a real problem where the inflammation is now, 5 years ago, we didn't have to worry about long COVID.
Yeah.
Now, apart from the 3 Bs, I got mold and long COVID kind of right below on the list between
Right.
the POTS and the adrenal dysfunction and everything else that you and I have been talking about. But
Yeah.
you may want to look at, I think, I don't have enough experience myself yet. I'm kind of still evaluating, but the study that just got published, it looks like it may be helpful in a certain percentage of patients.
That's great. That's great.
Yeah.
I will
And
definitely
your
look at that.
experience with semaglutide, you've been using it for,
So,
obviously, yeah, tell me a little bit about this, because obviously I'm using it. We know that a lot of the inflammation comes from the belly fat. A lot of people are now using either Wegovy or, any of the versions of Ozempic of this. Tell me a little bit about your experience in the community with it.
yeah, so I realized, I mean, I started using it with some patients who did, want to lose weight and whatever. And so we utilized the compounded version of it. So it's readily available. There's no hoops to jump through with insurance. It's much, much, much more affordable than the Ozempic or Wegovy or the brands. But what I've been finding is it's helping reduce inflammation in a lot of my patients at very low doses. And so it opens an opportunity, and it's definitely helping with cognition too, like just feeling. And it started, I had a patient who I've treated on and off for years. She's sort of mid-20s now and went off to college, came back. She's doing good things in the world, but she came to see me because she had done a microbiology test and wanted to go over the results. And I said, have you been? And she goes, oh my gosh, the last year I've been amazing. And I said, tell me what's been going on? What have you been doing? And she said, I've been on, it was Ozempic for her. And she said, I've lost 40 pounds. My joint pain is gone. My brain fog is gone. Like I feel better than I've ever felt. So yeah, literally you would look at that and go, okay, well, with less body weight, there's less stress on the joints, right? So that's an obvious connection. However, what I found beyond that is there is this sort of clear association with lowering inflammation in the body in general and lowering neuroinflammation.
Mhm.
And so there's a lot of kind of information out there about like the microdose, right? And I mean, I'm like, oh, there's nothing magic about microdosing semaglutide, right? It's like not this sort of just mystical fantasy thing. It's just like low dose. You just start low dose and stay low dose. And
And
so,
you're finding, by the way, the low dose is helping inflammation, and inflammation, by the way, of course, is the cause of every symptom people get, right, in almost every chronic disease. But
yeah,
you're finding even without the weight loss, the major weight loss at the low dose
yeah,
and it still is helping with the
correct.
inflammatory response.
Correct. Yes. So let's say if a starting dose is 0.25 milligrams is like the average starting dose. So I have patients who I start lower than that. It gets a bit tricky because, you know, it's so little fluid in this baby little insulin syringe that it comes to a point of like, how are you going to get such small amount of liquid to actually logistically get that in? But so the people that want to lose weight and have weight to lose, yeah, we can build up to the higher doses. Typically, as we titrate up monthly on the dose, I tell people who are even doing it for weight loss, you probably won't see much for the first 6 to 8 weeks, but don't worry about that. You know, like that'll come, but this is why we start low, offset side effects of, you know, nausea, GI upset, whatever, which still can happen in maybe 10% of people in my experience. So the weight loss folks do go up in dose because they want to get to the therapeutic dose for that. But the folks that don't want to lose weight, and look, if someone's underweight or really has to be careful about their weight, I'm not likely to do it. Like we've got to be sensible about, you know, it is an appetite suppressant.
Yes.
So we want to be mindful of people who don't have weight to lose. But generally speaking, and a lot of people will be like, oh, 5 pounds would be fine, 10 pounds would be fine. Like it's not a problem. But yeah, even at the lower doses, we don't have to titrate up into the therapeutic doses that are going to start kicking that weight loss more significantly, but they still get the benefit with the inflammation.
Right. And you know what? And I think going forward, and I have not integrated this as much, but I'm very interested. I'll be speaking to Dr. Jocker soon about, you know, even looking at once these patients are at a reasonable level of health, of even doing some fasting,
Mhm.
you know, to lower inflammation because it's resetting all of the epigenetics in the body, right? When you can do a good 5-day fast and kind of reset everything. I'm even thinking myself next year, like as I'm getting older, like I do a lot of things for my health. I, you know, keep down the sugar. I exercise. I get to sleep enough. I take a gazillion supplements. You wouldn't even want to know what I swallow every day. My whole family. No, I mean it's ridiculous, honest to God. What I'm. But but you know, I read now. You know, the colon cancer rates in the young kids is now double what it was from all the process. I read all of this and I go, all right, what can we do for longevity, right? As people are getting older, and I realize, you know, the fasting component, you can't really do it until people are well from Lyme.
Yes.
But they've used these kind of fasting clinics. I mean, they started in Russia and Germany, my God, 100 years ago. They were using it for rheumatoid arthritis and every disease and found that once you stopped eating and the insulin stopped secreting, right, and the body was getting into a state of autophagy where the mitochondria were overturning, it lowered inflammation and it reset the system. And as you know, as I keep doing year by year, and I keep thinking, where do we go? How do we keep improving what we're doing?
Yeah.
I'm just kind of wondering whether as people go forward, like this might even, have you had any experience with your patients doing it at this point?
Not longer term fasting like that. I have patients who do intermittent fasting,
Yeah.
but not longer term fasting. And I sort of feel the same way as you were just indicating, that they sort of have to have a certain level of wellness. Otherwise it just becomes so stressful on the body. It creates more problems than it solves. But I think the irony is like with, you know, modern medicine and developments and all our supplements and this and that and the other. And then where's the solution? Fasting. Like we're right back at the beginning.
Right. So we're kind of getting close. I knew you and I'd be speaking for close to an hour because it always happens. First of all, tell people how they can get in touch with you if people want to get more information. And also, please, apart from the email, tell them about the books that you've written, especially about diet and autoimmune. Explain a little bit about your history with that too.
Yeah, for sure. So the first book I wrote was called The Lyme Diet. It was supposed to be a patient handout. I sat down on my mum's kitchen table in Australia. So, Mum, I just got to write this patient handout because everyone asked me what to eat. And 6 months later, that became a book. So the Lyme Diet's really, you know, talking about how to eat to minimize inflammation, how to eat to balance adrenals and hormones and for neurotransmitter support and all of those kinds of things. So it's not that it's sort of rocket science in terms of the way it's just, but the information is presented in a way. It's like, if you have Lyme, this is why this matters, right? This is so people can understand like how foods are interacting with the different systems of their body. So the Lyme diet, then I wrote the beginner's guide to Lyme disease, which it's not truly a beginner's guide because it's pretty comprehensive, but it's ideal for people who may be newly diagnosed or have a family member who's struggling, or a friend, and sort of needs to understand all the pieces, right? What is the pleomorphism of Borrelia? What's she talking about? What are the co-infections? What are the antibiotic options? What are the natural options? There's a bit of a section on diet in there too. And then Lyme brain is the third one. So that's more like, the cognitive aspects, the neuropsychiatric aspects. And Lyme brain is actually available on Audible too. It's the only one of my books that is available on Audible. So, because we thought, which book should we put on Audible? Oh, how about Lyme brain? Because people with Lyme brain can't always read books.
And how can people get in touch with you if they want more information? What's the best email for you?
The email probably would be hello@drnicoladucharme.com. My practice is Restore Medicine. That does not have an E on the end. So it's RESTOR Medicine, and the website's restoremedicine.com. They can reach out there at info@restoremedicine.com. And then I also do have a website, drnicoladucharme.com, that has blog articles and other things on there. So
Great.
either one of those. And yeah, I am based in San Diego, but work with people really worldwide at this point.
Great. Last kind of parting thoughts here. So as far as the mindset of people with Lyme disease, we talked a little bit about it, but I always give people hope because I really am seeing much better results with, doing dapsone and pulling mold. And maybe just talk a little bit about like the 6 pillars that you're using. And it's just part of classical naturopath and mindset. Maybe just finish up a little bit and let's discuss that about some of the basic things that you're finding is also making a difference with people.
Yeah, so a couple of years ago, I got certified in neuro-linguistic programming and clinical hypnotherapy and EFT and a variety of different techniques. So I put a program together called the Transformational Healing Academy, and it's a mastering mindset program. So it's not quite the same as like the limbic, like the limbic rewiring programs, but it's a program that I offer personally myself in a small group coaching format. And next year, I'm going to be offering more programs that combine like the education piece. I've got a Lyme Ed online course. It's like 25 hours of education on Lyme disease, everything from antibiotics to hormones to detoxification, with one-on-one individualized care, with then this mindset program and group coaching calls. So I've offered that as a standalone program, and it's helping people to understand how the conscious mind works, how the subconscious mind works, how we can utilize the subconscious mind to support healing. So that is it's based on neuroplasticity. So that is a rewiring. But I teach people like, why are your thoughts so important? Like, what does that even matter to like having a chronic infection or a toxicity? And I teach people that with the scientific developments in our understanding of neuroplasticity, like you can choose a positive thought. And if you choose that positive thought, that healing thought, that empowering thought over and over again, you will literally strengthen the neural pathways of that thought. And if you choose a negative thought and have that over and over again, you will also strengthen that neural pathway. So I teach people and I give them actual tools as to how to put this into place, and give them, hypnosis tracks and journal activities and tapping techniques and different tools that they can implement day to day. And over that sort of 9-week period, like people will learn like, okay, my mindset matters to my healing. Like when we have a thought and that thought produces chemicals in the brain, every cell in our body other than our red blood cells has receptors for those chemicals, for those neurotransmitters, for those neuropeptides. So literally what you are thinking is influencing how your cells work on a physiological basis. And so I give a lot of education and help people understand how all of those things actually fit. And then I give them tools to be able to work with in their day-to-day life. And then I also just love the sense of community that comes with doing those group programs, because it's a positively oriented focus, but it's still an opportunity for people to be with other people who are going through the same things they are, who understand, so it's not like we're not trying to sweep anything under the rug and pretend it doesn't suck, but we're just saying, okay, you can think that it sucks, and then I need you to shift your thinking and choose something else. And it is a choice in the beginning. It's like working out. Like you don't some days you have to choose to do it, but the more you do it, the more, the stronger your muscles will get.
Yes.
And so that's kind of, that work just lights me up. I just love doing that work with people.
No, and I think it's great. I mean, I don't teach everyone meditation in my practice. I discuss it and I do one-on-one training when people need it. I'm in fact doing a medical detective Substack series now on meditation from the 40 plus years of studying with Tibetan lamas, because after people started, freaking out after the election and all the, emotions that were coming up, I thought, this is a good opportunity because people's emotions are going to affect their health. Let me teach them some of the basics I learned from, people way smarter than I am who've passed on this lineage of incredible information. So I've been doing a 5-part series. I agree with you. I mean, I've even seen, and this is years ago, I remember these stories, just like the gentleman I was saying earlier, the people that hold on to these negative thoughts about themselves who have had trauma, and a lot of times it is from trauma, physical, emotional, sexual trauma early on. It's like the immune system basically gets wired that they don't deserve to be happy. They don't deserve to be healthy. And I have seen where you can hit the bugs, you can pull out the mold, you can deal with the gut, you can do everything you want. But if that pillar, if that nail in their foot is not treated properly, they will not get better. And I've seen it happen where all of a sudden they have the aha moment with those psychological things that come up. They recognize what it was, they get through it. And all of a sudden, the things that weren't working, all of a sudden start working. And it's like, for those who don't believe in mind-body medicine, for us who've been in the field this way, I think, this is not some woo-woo medicine. This is real life stuff that really, I think has big implications for people. So that's great. I'm glad you've incorporated that into your regular practice. I think it's very important.
It's so important. And I've had patients who've done the program who said, oh my gosh, I wish I'd had this like right when I was getting started. You would have changed everything.
Yes.
Yeah.
Nicola, thank you. This was great. I know people are going to get a lot out of it. And I think they're going to, everyone who listens to these Dr. Tar summits, they're getting a lot of different perspective from different people. But I think the one thing that everyone is hearing is the 3 P's of Borrelia babesia bark. I mean, they're getting it from all sides. It's like, it doesn't matter who we're speaking to.
Yeah.
It's like the mind is important and the diet is
common thread. Yep. You got to pick the common thread.
Yeah, so I think it's great, and I think you really highlighted those wells during the talk. So thank you. And again, one last time, just for the email for people to get in touch, because I know people are going to want to just one last time, please share it.
Yes, info@restoremedicine.com, and there is no E on the end of restore. So info@restormedicine.com.
Okay, thank you so much.
You're
so for everyone who's been listening,
yes,
it's been great. My name is Dr. Richard Horowitz, co-host of the Dr. Talk Healing Lyme Summit. I've been speaking to Dr. Nicola Ducharme. She's been in the field for a long time as a great naturopath doing this. So please join us for another episode soon. Thank you for tuning in.